Welcome to the Idea Pod, a podcast dedicated to exploring and interrogating professional, biomedical and applied ethics at the University of Leeds.
Hi everyone, so today I'm here with Alina to talk about the results or the outcome of her dissertation research. So, hi Alina.
Hey everyone. I'll be talking a little bit about my dissertation that I did for the Idea Center for the Masters in MA Medical Ethics.
Okay, great. So could you just for the audience, just give them a bit of a sort of brief summary of what the project's about?
Yeah, so essentially I focused on the ethics of blame and also the concept of epistemic injustices in the context of borderline personality disorder. Essentially what I argued was that the way that we treat patients with borderline personality disorder is unjust. So I focused on moral responsibility and the way that we blame patients, later arguing that the way that we blame them is what Fricker calls hermeneutical injustice. So it's quite a chunky dissertation, but when I split it up into 4 sections, it made a bit more sense.
So I guess perhaps it's useful to mention that I suppose there's a gender element to this as well, right?
Yeah, so I argued that part of the reason that we blame patients with borderline personality disorder is to do with the fact that it's a condition that we often associate with women and traits associated with femininity. And part of being part of that marginalized group means that sometimes we inappropriately blame them for things such as outbursts of anger, for example.
So I'm not really an expert on the technical side here, but as I understand it, it's a diagnosis that's much more common for women than men. Is that right?
Yes, that's right. So I think something like 90% of people diagnosed with borderline personality disorder will be a woman. That's not to say that men never get diagnosed with it, but it is something that we associate with women. And even if you look at the history of psychiatry and the way that borderline personality disorder has kind of come about, it does tend to be associated with femininity.
Okay, great. So just for any audience members who are not familiar, could you just tell us a little bit more about what borderline personality disorder is?
Yeah, of course. So borderline personality disorder is essentially, it's characterized by behaviors such as frantic efforts to avoid abandonment, intense relationships, being impulsive, things like recurrent suicidal behavior, inappropriate anger, and feelings of emptiness. So a lot of these symptoms are kind of seen as a long-term thing as opposed to shorter illnesses such as a depressive episode. So it's a personality problem more than a short-term brain problem, if that makes sense.
So would that be the difference between a personality disorder and other kind of diagnoses?
Yeah, so generally personality disorders are seen as enduring, persistent, and pervasive bits of a person's behavior as opposed to a shorter-term problem.
So I think things like antisocial personality disorder or things like that we kind of know of, like the idea, I guess, is that people will have these traits for the rest of their lives, and all that can really be done is to manage them. Is that right?
Yeah, that is the idea.
Okay, so before we get into the specifics of what you argued, it'd be interesting to know kind of how you arrived on this project. So what got you interested in this? What got you thinking about this topic?
Yeah, so I spent a bit of time on a psychiatric ward. It was a women's psychiatric ward during my 3rd year of medical school. And that's where I kind of started to notice that patients with borderline personality disorder were being treated in a way that made me feel uncomfortable. And it was something that I didn't really have a vocabulary for at the time, but I found that patients were often being labeled as difficult or manipulative, and often they weren't really being treated in a way that I think is right, to summarize it really. So I remember people saying things like, oh, they know exactly what they're doing when they were really unwell, and having outbursts of anger at staff and things like that. And it kind of felt like a way of blaming patients for things that clinicians themselves diagnose them with. So I found it a bit funny that people were being diagnosed with a disorder that suggests that they have problems with controlling their emotions, and then later being blamed for exhibiting a symptom of it, I guess.
Yeah, so this idea that they're being blamed for their diagnoses in a way that we perhaps wouldn't blame people who've been diagnosed with another kind of psychiatric disorder or personality disorder. We'd kind of think that the disorder sort of excused them in some sense from blame.
Yeah, so there was one study that I looked at while I was writing it, which was quite interesting, which looked at the way that we treat patients with schizophrenia as opposed to patients with personality disorders. And I think that really captures it, because when patients with schizophrenia clearly are having hallucinations, we don't tend to think that it's a personal failing on their part. Whereas often when a patient with borderline personality disorder has problems in relationships with others, we do blame them.
Yeah, and I suppose the same even with sort of schizophrenia leading to serious violent crimes. People often feel you shouldn't blame this person for that because they were in the grip of this illness, or this diagnosis sort of means that, yeah, they're not to blame in some sense. I mean, obviously, this is a philosophy podcast, but discussing blame, responsibility, and these kind of things are very complex topics, even for philosophy. So perhaps we should get into the sort of the technical aspects of your argument.
Yeah, I mean, that's essentially what the first section of my dissertation was about. It was looking at moral responsibility, because I think that is where you have to start with this topic, because when we're talking about blame, we need to figure out whether or not people can be responsible in the first place, really, which is a massive topic within itself. So there's quite a bit to go through, but generally speaking, I think responsibility hinges on whether or not you understand what you're doing. So having an epistemic understanding of what it is that you're carrying out, and as well as, I guess, understanding the consequences of your actions. So being able to have that foresight.
And when we're distinguishing blame from responsibility, how would we be doing that?
That is a massive topic within itself, and a lot of people have different views on it. A lot of philosophers, I think, would say that they are one and the same, that to be morally responsible for something, that's essentially saying that they're being praised or blamed for something. I think there is one author who I found really interesting in the context of this. Picard talks a lot about how blame can be separated from responsibility. And she talks about how that is particularly pertinent to situations like this, where patients have a disorder that might stop them from fully understanding the consequences of their actions. I can go into that in a bit more detail.
So would this be a little bit about kind of so we can say somebody is morally responsible for their actions, and that's kind of, in some sense, like an absolute judgment about what's sort of true, whereas blaming seems a little bit more about the sort of the social practices and the culture, right? The kind of, it's like holding somebody to account, or sort of giving somebody, like treating somebody in a negative way as a result of holding them responsible. Right?
Yeah, that's the way I see it. I see responsibility as the first part, and praise and blame as the second part that we choose to enact, I guess. So you can say that someone is responsible for something, and then you can withhold the blame that you feel that they deserve as a response to that.
Yeah, so like I guess sort of a classic example of that might be like with a child or something. As a parent, you might think this kid knows what they're doing. They've done something that had a negative effect, but there might be sort of good reasons as a parent why you think it's helpful to not blame them, to kind of talk through things with them and to treat them in a different way.
Yeah, that is essentially what I think is relevant here as well, because there are good reasons to not blame patients. We know that when we blame patients, we're also hindering their recovery. And so I think similar to that example with the child, we're pushing patients to not engage with services. And making it more difficult for them to lead a normal life, really, I think, when we label them as difficult or bad. So.
Okay, great. So I remember from the dissertation you had these two these two conditions of trying to understand whether patients with borderline personality disorder diagnoses could be held responsible or morally responsible for their actions. And we're going to separate this for now from the question of blame, right? So it'd be great to hear you talk a little bit more about these two conditions.
Yeah, so I talk about the two Aristotelian conditions to moral responsibility, which basically helps you decide whether or not someone can be praised or blamed for an action. And so the first one is the freedom relevant condition. So that one's basically about whether or not someone makes a choice freely. So I think the common example that often gets given here is if you have a gun to your head, then obviously you're not making a choice freely. So in the terms of borderline personality disorder, obviously when you're attacking staff or when you're having problems in relationships, you don't usually have a gun to your head. But I think the way that it can be understood in that context is whether or not their behavior is the inevitable consequence of the traumatic upbringing that a lot of patients have, or a biological vulnerability, or something wrong with your brain that prevents you from being able to carry out those actions. So that is the way that I understood the freedom relevant condition.
So is the patient with the borderline personality diagnosis here in kind of a different situation to the sort of the average person when they're sort of acting in a way that we might think is inappropriate or antisocial or whatever?
So different authors think different things. Personally, I think that there is a middle ground that we can maybe decide on here. So I do think that there is a biological element to it, and there is also an element of if you've only ever learned that this is the way to communicate with other people, then it makes sense that that's the way that you communicate with other people. So I think upbringing also plays a role. But at the same time, it's tricky to say that the past determines the future entirely. I think that people also have the ability to make their own choices, and that is what I argued in terms of the freedom relevant condition. I did end up saying that it's not a good enough reason to say that borderline personality disorder patients don't know what they're doing or don't have any choice here, because also patients, they do get better with treatment, and that's proof in itself that we do have the freedom to make our own choices.
So in a kind of perhaps a very qualified way, the patient suffering or diagnosed rather with the borderline personality disorder, they could meet the freedom relevant conditions. So you mentioned this second condition, this kind of understanding condition. So could you, for the audience, it'd be great to hear a little bit more about that.
Yeah, so I went through the freedom relevant condition first, but then I went on to the epistemic understanding condition, which essentially, do you understand what you were doing? Do you understand the consequences of your actions? And that one, I think I was a bit conflicted about it, because I do think that what defines borderline personality disorder is an inability to think because you're so clouded by emotion. And sometimes that seems to be what prevents patients from acting in a way that might be more acceptable. So the impulsivity, I think that kind of means that patients might not necessarily understand the consequences of their actions.
I suppose an interesting question here, for me at least, is it seems in the moment I can completely understand how the sort of the judgment of the individual concerned would be clouded. But would you want to say that sort of on reflection, their judgment would still be clouded, or would they be able to kind of understand the significance of their actions in a case like that, do you think? Like, say if they'd behaved very hostilely towards staff or something.
So I think it's quite tricky to say, especially in hospital, because what I find in hospital is that no one is at their best because they're unwell enough that they need to be in hospital. And so I find it quite inappropriate when I feel like we need to give patients in hospital more leeway when they're having outbursts of anger, when they're just generally not behaving well, because to be in hospital in the first place means that you have to be in a really bad place. So essentially what I argued in this area was just to say that we need to give patients more leeway, and understand that, if you think about even yourself, I think when you're, in a stressful situation, you're more likely to behave impulsively. And I think that's very true for them as well. Yeah.
Yeah, for sure. Because it kind of made me think of, if you imagine somebody sort of in a classic scenario where somebody commits a violent crime or something, usually like, aside from something like robbery or something, if you're talking about like a physical assault or something, generally, like, there's a huge extent to which you might think that their judgment was massively clouded by emotions in some way. But I guess you want to say here that for the patient with the borderline personality diagnosis, they're in a sort of a slightly different boat to the average individual on the street who is clouded by emotion when they make sort of a poor choice.
Yeah, exactly. That's exactly it.
So we kind of, I guess, like a conclusion here of sorts, which is that the borderline personality disorder patient can be held morally responsible for their actions, but perhaps to a slightly lesser extent than somebody not with this diagnosis, right?
Yeah, like I said before, I think it's about, I think there's middle ground. I don't think that they're fully responsible, but I also don't think that they're completely not responsible at all. And that is, I think, what leads to the idea of partial responsibility, which is what I looked at next. So the idea that someone can be superficially responsible for actions without being deeply responsible for them.
Could you give kind of a example of that?
Yeah, so Susan Wolf gave a really, I can't remember the name of the person that they talked about, but they talked about someone who had grown up in a situation where both of their parents were horrible people who murdered people all the time, or something quite strange like that. And if that's the only image of a behavior that you have, then it would make sense for that person to behave like that as an adult. And so I think that example kind of shows that someone could be superficially responsible. There's nothing necessarily stopping them from carrying out those acts. But at the same time, we don't hold them deeply responsible in the way that we would someone who had a secure upbringing where they knew the difference between, I guess, not murdering people and murdering people.
Okay. Yeah. So I suppose this is where your thesis gets very kind of novel and interesting, because you want to kind of, in these cases, decouple responsibility and blame a little bit. Is that right?
Yeah, so that brings me back to Pickard, who I think is the first person who really did that. And the idea that moral responsibility doesn't have to entail praise and blame. So the way Pickard puts it is saying that we can recognize that someone's blameworthy. We can recognize that we should blame them, maybe, but we don't actually have to blame them. We can withhold that final bit. So it's about that idea of recognizing responsibility and withholding that second judgment almost.
So I suppose, is this something that we would want to do in other cases, to separate responsibility and praise and blame? Or is this something that it looks kind of primarily useful to do in these sort of cases with this particular kind of patient?
I mean, I think we've talked a little bit about, I guess, crime already, and I think that's another area where I can see that being quite useful, just because I think we have to think about what the end goal is when we praise or blame people. And if we're looking for people to recover, if we're looking for people to move forward and I guess behave in a way that is more in line with what society wants, or it doesn't make sense to do things that make that more difficult for them. So, I mean, that's relevant to personality disorders, but I can also definitely see how that could be relevant to the criminal justice system as well. Yeah.
Yeah, it's something that I find interesting, and I'm not really sure where my own views lie on this. This idea of sort of taking like punishment or the retributive urge entirely out of sort of judgments about how we ought to act when people commit sort of serious violent crimes or something like that. I can certainly understand the view. Well, I think I can kind of understand both sides a little bit. Like, I feel like when somebody does something horrendous that you feel has these terrible consequences and things, you might kind of feel like, yeah, I think there's a retributive urge that a lot of people feel, like, are wanting like good things to happen to good people and bad things to happen to bad people. But then, as you say, there's this kind of, I mean, for most people, the primary purpose, I think, of like the prison system and the like is obviously reform. It's like a practical purpose rather than simply some kind of medieval purpose. So yeah, I find myself conflicted on that perhaps in general. I can see sort of the weight of both sides, but it seems like this is a more interesting and specific case as well, right?
Yeah, I agree. And it's tricky with personality disorders because we are also essentially saying it's a part of their personality as opposed to a specific act that they've done, which I think is where it's different from, I guess, crime, because we're making it about them as people.
Yeah, I mean, perhaps this is to get a touch off topic, but this debate feels to me a little bit analogous to the debate around sort of psychopathy and how we ought to treat sort of psychopathic murderers and things, like whether they can be held responsible, what ought to be done, like how we ought to act in these cases where it looks like perhaps, I guess the issue that comes up in the debates around psychopaths is the idea that not only do they not really fully understand what they've done in the way that somebody with like a normal moral faculty would, but also perhaps that this idea of psychopaths is sort of irredeemable, like you can't get them to change their behavior patterns. I suppose it's implicit in what you're saying that perhaps with people who have the borderline personality disorder diagnoses, that's not the case, right? Their behavior patterns can be changed.
Yeah, that's the tricky bit, because it's strange. I find it strange how we talk about it as a persistent and pervasive disorder that's not really going to go away. But then we also know that things like dialectical talk therapy can improve symptoms. And I think that's just generally a thing that's tricky about psychiatry in general, is that it's not really as black and white as other areas of medicine, or there's no brain scan that can say, yes, you have this problem. And that's true for psychopathy as well. I think that's why it's tricky to decide where the line is.
Yeah, so I suppose in this case, in the case of the borderline personality disorder patients, part of why we might want to separate responsibility and blame is precisely for these kind of practical reasons, right? That it looks like there might be negative consequences of blaming the patient. Is that right?
Yeah, that is essentially why I think it's important too, because at the end of the day, I do think it hinders recovery quite significantly.
So one of the significant reasons to withhold blame in a case like this would be that blame looks like it's counterproductive to the patient's recovery.
Yeah.
So we then kind of move on to, well, I suppose we can move on to some of the other interesting and perhaps more complicated territory that the dissertation covers around gender bias and around the concept of hermeneutical injustice, which I suspect is something that many of our listeners might be unfamiliar with.
Yeah. So the second half of my dissertation, essentially, it So I started with moral responsibility, and then after deciding that patients should be partially responsible and that we should withhold blame from them, that kind of led me to trying to figure out why we still blame them, because I think most of us who've been on psychiatric wards would agree that the label of being difficult and manipulative it's really common, and I think most people will have seen it on psych wards. So I was trying to figure out why that happens anyways. And one of the things that I found really interesting is, so I've worked in some women's services before, and a lot of the people who come through those doors often get a diagnosis of borderline personality disorder. And a lot of those services also tend to have quite feminist perspectives. And I found that they talked about borderline personality disorder in a very different way to the medical side of things. And they often talked about borderline personality disorder with a bit of an eye roll and said that, it's a bit of a silly diagnosis. And so that kind of led me to look at what, I guess, feminist perspectives have to say on it. And what I found was that a lot of people see borderline personality disorder as a bit of an extension of hysteria, which is a bit of an outdated diagnosis in psychiatry, but is essentially a diagnosis that a lot of women used to get for essentially being quite emotional, I guess.
So would the thought here, I suppose the part of the thought here is that the characteristics that we associate with borderline personality disorder are perhaps characteristics that have been stigmatized in women for a long time.
Yeah, that is essentially it.
But I guess the thing that I wonder here is, I suppose part of what's going on here is it the over-diagnoses of borderline personality disorder in female patients.
Yeah, so what I did find was that, so some people think it's about over-diagnosing women. I think part of it is also just the way that we characterize the label in itself, because women are getting diagnosed with it, we also associate negative things with it, I guess. I think a good way to think about it is to think about PTSD as opposed to borderline personality disorder, because PTSD is a diagnosis that kind of came up as a result of, I guess, at its core, men going to war, whereas BPD, a lot of patients have similar experiences, but both diagnoses are characterized in very different ways. So some authors think that they are essentially the same thing. We've just gendered them very differently.
Yeah, I can certainly see that, with at least traditionally PTSD being associated with so-called shell shock and the idea of like male experience of trauma and conflict and things, whereas female experience of trauma out in kind of perhaps the domestic sphere or something is labeled in a very different way. And yeah, I expect that both patient groups are probably treated quite differently.
Yeah, so that is what I find interesting, because I think the label of PTSD is it externalizes it to an external source, whereas BPD is very much about a person's personality. It's about those pervasive traits within a person, as opposed to an external trauma. And I think that is quite indicative also of just how women and men present in psychiatry in general. Like, I find it interesting that, if you compare antisocial personality disorder to borderline personality disorder, antisocial personality disorder, where people tend to act out a bit more, that tends to be diagnosed in men more than it does in women, whereas BPD tends to be about internalizing those things. And I think that also ties in with the idea of blame, which is why I think blame is a form of internalizing things.
Yeah, no, definitely. It's very, very interesting. I think in some sense that kind of gets to the real crux of the argument of the dissertation, as I understand it, in that you kind of have the same set of symptoms, perhaps in the PTSD diagnosis and the borderline personality disorder diagnosis. But in one case, as you say, the idea is that the PTSD sufferer was kind of caused to act that way by external events like a war or some kind of trauma, and as such, they're not really to blame, whereas in some sense, the cause of the borderline personality disorder is seen to sort of, lie within in some sense, to be more of the person, and we kind of see the person as to blame for those symptoms or those behaviors.
Yeah. And I don't think it's just psychiatry either that holds those ideas. I think even if you look at things like endometriosis in women, there is this general idea, I think, in the medical world about women fabricating their pain, or that their pain is in their head as opposed to external or due to a somatic cause.
With the sort of the implicit thought there that they're somehow to blame in those cases.
Yeah, so when I talk about endometriosis, a lot of women tend to get diagnosed with endometriosis quite late, despite it being a physical problem, because a lot of clinicians, well, historically, a lot of clinicians would often presume that it was people just being a bit overdramatic, I guess, about period pain, really.
So, this is some very interesting stuff, and I mean, I broadly agree, and I'm very sympathetic to a lot of these arguments, despite perhaps not having the level of sort of psychiatric and medical knowledge necessary to say more than that. But so let's move on to this concept of a hermeneutical injustice or hermeneutical injustice. So this might be something that the audience is unfamiliar with, and it's perhaps something that's very much kind of at the, I would say perhaps like at the sort of cutting edge of what's going on in modern analytic philosophy these days. So, yeah.
Yeah, so, I mean, I focus on Miranda Fricker's understanding of the word or the phrase hermeneutical injustice. So Fricker talks a lot about epistemic injustices, which is basically the idea of injustices that occur when there's a power dynamic at play. And hermeneutical injustice in particular is when marginalized groups, when they don't get to really decide their own label or decide their own experience. So it's about the idea of, it's essentially about not being able to decide your own labels for yourself, and not being able to, I'm struggling for words, but I find that quite funny, just because that is essentially what a hermeneutical injustice is. It's not having the words or the language to put your experience into a way that other people can understand it, because you're part of that lower group.
So I seem to remember that an example, I mean, it's a while since I've read this, but I seem to remember an example that Miranda Fricker brings up is the idea of, say, sort of sexual assault or sexual harassment, and how kind of there was this experience that was sort of perhaps predominantly or disproportionately experienced by women, but there wasn't kind of a terminology for it out there.
Yeah, and that is essentially what hermeneutical injustice is. It's not having terminology for things, and that is, I think, one of the most common examples of it is sexual harassment, which I think which is getting a little bit better. There was also a good example that she gave that I talked about in my dissertation about postpartum depression, of this woman during the 60s, kind of sitting with a group of other women and kind of having that moment where she realizes, and she's like, oh, this is actually a really common experience, and this isn't something that I'm just making up in my head, and kind of coming to an understanding and creating a language together to describe it.
So is part of the injustice here not just the not having the language, the words, the label, is it the being mislabeled as well?
Yeah, so Fricker talks about how Fricker talks a little bit about how what makes something an injustice is when the credibility of your word is deflated. And I kind of went the other way, and I said, I think the problem here is that we're excessively inflating the credibility of people's words. So we're putting excessive blame on people. We're not recognizing the way that their negative experiences have impacted them to make them the way they are today. And so we're giving them excess responsibility when we should be withholding that blame.
So we're perhaps sort of like taking what they say at face value rather than thinking about the sort of the structural considerations or the diagnoses and things that are leading to that.
Yeah, I think that's essentially that's at the heart of epistemic injustice, is essentially taking context into account and looking at the structural things at play.
So whilst I suppose it's slightly different because when we want to talk about the responsibility of children, it's much more complicated and gets into all sorts of issues. But like, it might be like, an analogy here could be that you sort of, a child, you know, says, I hate you, I want you to die or something, and they're having like a tantrum or whatever, and you kind of, you take that seriously. You act as though what they're saying is meant with terrible intent and that they're a terrible person, rather than sort of understanding their childhood and the situation and the fact they're sort of saying something that they don't really mean, and like.
Yeah, I think that's a good example to put it into context.
So I suppose alongside this idea of hermeneutical injustice, we've got this sort of other concept that's sort of discussed around the same sort of topic of sort of testimonial injustice. And with testimonial injustice, I think, or epistemic injustices like this kind, it's like the idea that you sort of are not taken as a credible source when you say certain things due to sort of power dynamics and social prejudices and the like. But in a funny sort of way, what you're kind of saying here is like a flipped version of that, where somebody's being taken as a credible source where really they shouldn't be.
Yeah, so the example that Fricker gives for testimonial injustices is kind of the classic example of a police officer not believing someone who's Black for the simple reason that, you know, the power dynamic at play there. And I think this is, like you said, the reverse, where I think it's, say, a patient having an angry outburst and a doctor or any other clinician giving excessive blame to that situation, or saying that they're excessively responsible. So it's almost, it is the opposite.
So that seems like a very, very interesting and novel thesis, and something that actually nobody has really said before, actually, and builds very interestingly on this pre-existing work in sort of testimonial injustice and feminist philosophy of language and the like. So, I think this is a very interesting place for a dissertation to end up. So, I don't know, is it something you've thought more about since then, or something that you've kind of noticed in everyday life? Or, I just wonder sort of, where are you now, sort of a few months down the line?
Yeah, I think it's strange, because I think with talking about testimonial and hermeneutical injustices, because it's quite a new area, there's not much to fall back on and to read up on. So I'm still kind of forming my own opinion, I think, and there's not much to read into to kind of help me decide where I stand on things. I think the part of the dissertation that I've thought about the most since is, I guess, the purpose of disorder labels in themselves. Because sometimes I think would be better if we switched to the PTSD diagnosis, and I don't know if it would be better. I don't know if you would just be transferring on all the same stereotypes to that. So that's, I think, where I stand now. A few months down the line, I'm thinking about that quite a bit.
Yeah, this is a very interesting thought, and it's one that had kind of occurred to me from sort of, speaking to people in my own life, this idea that sort of people prefer a PTSD diagnosis to a personality disorder diagnosis in some sense.
Yeah. And I think everyone has their own opinion on it, and I don't know where I stand on it. I know some people also don't like the idea of it being a disorder at all, and they prefer the idea that we just understand that life experiences have made people in a certain way. Because when we say that someone has PTSD, we're still saying that they have a problem. And I think, in a way, we're still not externalizing, or we're still not saying that maybe it's the way society is built. Maybe it's not the structural inequalities that are at play. It's still a personal problem. when you say it's PTSD?
Yeah, I mean, this is something that I sometimes thought about with the idea of PTSD, and particularly with people's experiences of war, the idea that if everyone has, or generally people come back with this common experience of being sort of deeply traumatized by sort of being involved in this sort of violence on this industrial scale, perhaps that says more about the violence on the industrial scale than it says about the specific individuals.
Yeah, I think that is essentially the idea, and that's why I'm not really sure where I stand myself. And, you know, I think another thing to think about is also why doesn't everyone why do some people get borderline personality disorder and why do other people not get it? And why do some people get PTSD and why don't others? So
yeah,
answered.
I mean, it almost with PTSD in some sense perhaps flips it the other way, where you kind of look at the people who can exist in the face of mass death and constant stress and come back apparently normal as the ones who might be the people who might be in some sense more unusual. Or
yeah, I agree.
Warranting some kind of label. But thank you. I mean, this has been very interesting, and it was a very interesting project to supervise, and I'm sure this is something that will develop in the future.
Yeah, thank you.
The Idea Pod is produced by the Interdisciplinary Ethics Applied Centre at the University of Leeds. Find out more at leeds.ac.uk/ethics. Music composed and conducted by George Armitage.